Good morning, Dr. Serena. How are you?
Good morning and welcome everyone.
Absolutely. Welcome everyone. Whether it's the morning, afternoon, evening, depending on what part of the world you're in. It's one of the exciting things about being obviously in this venue is that you can attend from anywhere in the world. So I think we had something like 42 countries represented in the registration. So that's pretty exciting. I want to welcome everybody to the Topical Oxygen Therapy event, Breathing Life into Chronic Non-Healing Wounds, powered by LER Expo. My name is Rich Dubin. I'm the founder and publisher of Lower Extremity Review Magazine and CEO of LER Expo. I've been in the lower extremity space for over 35 years. Super honored to be facilitating this awesome educational event. A big thanks goes out to NATROX for their unrestricted educational grant for this event. One of the things we always do is we ask everybody to key in the chat where you're from. So in the, you hit the chat in the upper right, and in the bottom, just key in, join the conversation, and let us know where you're from. We'd love to see what part of the country, part of the world you're attending from. It kind of brings it home for us. Hi, Sonia. Good to see you, and glad you're here. Dr. Kent from Texas. Dieter, good to see you, my friend, from New Hampshire. Keep them coming. A lot of the names I recognize. So let us continue to see where you're from and keep keying in the chat. Also get you familiar with how the platform works. So I'm going to go over a couple of simple housekeeping items. Obviously, you see the chat. That's number one. Click in the upper right-hand corner, and you can ask your question in the chat. There's a people icon right below that. So you can click that, see who's in the room, see if you see any colleagues, any old friends, people you haven't seen in a while. You can message them in the background and have a chat with them. And there's also some emojis, which I see hand claps and thumbs up and all of that going on. We encourage you to use those. Those keep us engaged and also keep you engaged and let us know how well the speaker is doing. So really, we're just looking to make this a great event. We need your involvement. So listen, learn, and retain. And without further ado, I'd like to introduce our first speaker, Dr. Thomas Serena, vascular surgeon and founder and medical director of SerenaGroup, a group of wound care clinics. And I'm just going to really turn it over to you, Dr. Serena.
Thanks, Rich. And thank you, everybody, for joining. I'm going to go ahead and share my screen so that we can get started. And there we go.
Crank it up. Perfect.
All righty. See you in a minute, Rich. So welcome again, everybody. I'm Tom Serena, and I am the founder and CEO of the SerenaGroup family of wound and hyperbaric centers, as well as the founder of SerenaGroup Research, which is a contract research organization. And the first question is really, why is a hyperbaric guy speaking about topical oxygen? Well, we actually were involved in one of the pivotal clinical trials in topical oxygen, which I'll speak about in just a minute. But I think it's really important. I look at it as oxygen being a modality that promotes healing. And if you think about it, there are different doses, and we'll have some interesting ideas about how we might use oxygen and topical and hyperbaric in some kind of conjunction. Food for thought. But let's go ahead and get started. Oxygen, we all know, it's important for wound healing. It's important in every phase of the wound healing cascade. You need neutrophils need oxygen to kill. Greg Schultz is going to be speaking in a minute about really more how the mechanism of how oxygen works. It clearly changes the microbiome in the wound. During the proliferative phase, collagen, you need oxygen to promote collagen cross-linking for angiogenesis, keratinocyte migration. So this is not a surprise to anybody on this call that oxygen is important in all the aspects of wound healing. Welcome to the wound clinic. And these are our patients. Our patients have multiple medical problems that lead to the low delivery of oxygen to the wound. That can be peripheral arterial disease, edema, such as our venous leg ulcer patients. It could be trauma. It could be compromised pulmonary health. The wound itself may have problems, such as problems with the microvasculature. There can be local regional perfusion problems. There can be non-viable tissue, and of course, infection and biofilm that Dr. Schultz will be speaking about shortly. And then even on a cellular level, you can have just an overactive immune response with too many reactive oxygen species. It could be, again, go back to the presence of bacteria and fungal elements that will compete for oxygen in the wound. So you may have heard about topical oxygen. There's a number of different modalities, and I'm going to go through this quickly, but there is cyclical or intermittent topical oxygen. This is similar in mechanism, or similar in modality to hyperbaric, in that you give it for a period of time every day. And then not available here in the U.S., but other places, is a hemoglobin spray, which you can spray on, and then porcine hemoglobin can take oxygen into the wound. And then what we're going to focus on today is continuous topical oxygen therapy. And now this is oxygen that diffuses into the wound, and there's a constant delivery of oxygen. Now, it has some advantages in our world, which is becoming increasingly more mobile. Having the patient do it, having it go home and have the patient wear it. It's very easy. Others will show you what it looks like, but it's easy to wear. My patients have no problem with it. This is a huge advantage. We know that wound care is moving into the patient's home more and more. So this is absolutely essential. Both cyclical topical oxygen and continuous are supported by a very high level of evidence. You can use continuous oxygen with other therapies. And again, it's lightweight, and you can stick it in your pocket or attached to your belt. A lot of advantages to continuous topical oxygen. All right. So let's just go over those quickly. You put this on the wound bed. You can observe it. We change it typically once a week. And it also, we'll talk about reducing pain in a minute. But that is something we've seen, and it's something we need to clarify further, because I don't know that I really understand it. The pain relief is pretty sudden within the first couple of weeks. Now, take a venous leg ulcer, and any venous leg ulcer that you have, and you start putting in compression and putting other therapies on it, eventually the pain starts to subside. But this is before that. It's an early pain reduction, and I think that's something that's really fascinating. The evidence for continuous topical oxygen is growing, and you can see here that there's been a large number of publications on topical oxygen. There is a growing body of evidence that supports the use of this device in hard-to-heal wounds. All right, so when you look at the evidence, we now have 5 meta-analysis, and Marissa Carter's there in 2022. I was very happy to be part of that group. But there's 5 meta-analysis and multiple randomized controlled clinical trials. Again, this is a building level of evidence that we have that topical oxygen is an effective modality. Most of this is diabetic foot ulcers, but we'll share some evidence on other modalities, other wound types as well. So recent clinical evidence before 2021 on the use of topical oxygen diabetic foot ulcers. Here you see 3 papers, again, positive results. Now, we all know Centers for Medicare and Medicaid Services, or CMS. So they looked at these studies and said, well, you know what? They're good, particularly the Niederauer study in 2018. However, we don't think you treated our patients. So Medicare published a brief and said, look, clinical trial people, you need to start testing your products on our patients, Medicare beneficiaries. They need a certain percentage to be over 65. You need to follow the national coverage determination, which says you need 30 days of standard of care in which the wound hasn't healed significantly during that time. And for the most part, we use a percent area reduction, or the amount of decrease in size, of about 40% in 4 weeks. So taking this advice from Medicare, we designed the next clinical trial. This trial was sponsored by NATROX, but conducted by SerenaGroup Research. And I really like this design. And I'd like to take credit for the design, but this is the one time I've got to give Medicare credit for something. So all the participants in this trial proceeded through a 4-week run-in. Now, the way we did it, we had 2 weeks that was historical, and then we had 2 weeks that was very aggressive standard of care. Oh, and by the way, we are going to publish this trial design. Actually, it's already set to be published next month in the March issue of the Journal of Wound Care. And if you really are interested in getting down into the details of how we designed this trial, then I suggest you get that article. All right, back to the lecture. So everybody had a 4-week run-in period. 2 weeks was historical, 2-week very aggressive standard of care, debridement, sharp debridement, which we oversaw. We then had a reduction in bacterial burden. And everybody in this trial got total contact casting. So the gold standard for offloading. At least half of the participants had to be over the age of 65. So therefore, they were Medicare beneficiaries. If you made it through the run-in period, which a lot of patients didn't, you were randomized to topical oxygen and standard of care or standard of care alone for 12 weeks, 12 weeks being a standard endpoint. This was conducted at 19 clinical sites across the United States, and you can see a number of the investigators are below, including 2 of our speakers, Dr. Wendy Cole and Dr. Naz Wahab. So when we look at the consort diagram, we can really shows you what I think is the next stage in clinical trial design. Look, the early trials that I did in diabetic foot ulcers, we just took everybody who came in with a diabetic foot ulcer. And to be honest, most of those wounds I could have healed with dog poop and a total contact cast. Well, I am not advocating the use of canine feces for anything. However, the point is that you have to get rid of the easy to heal patients. And so we assessed 224 patients in this clinical for this clinical trial. And that's a lot. But we look below at randomized, we only randomized 145. Why? What was the biggest problem we had? The number one problem was that the wound reduced by more than 20% during that aggressive wound care phase. And that was 34 of the 50 patients that were excluded during the second week. It's a huge number. Now, remember, all these patients before they were screened had to have 4 weeks of standard of care. So, or 4 weeks of the ulcer, and presumably 4 weeks of standard of care. So 8 weeks of an open ulcer by the time they get to the point of randomization. The conclusion is that a lot of these patients weren't getting aggressive standard of care. We really don't want them in our clinical trials testing advanced wound care products. And that's what Medicare says. Medicare publishes their coverage determination, and they say, look, you've got to do 4 good weeks of standard of care. If the wound doesn't heal, then you can use an advanced product. And it's exactly what we did in this trial. And what I said when we've met with Medicare after the publication of this trial is, listen, the patients in this trial are your patients. These are the patients that will doctors will apply for advanced wound therapy for. All right, so everybody got standard of care. We mentioned that already. And then wound measurements, we used AI-driven planimetry to measure the wounds. And this is nice because you're not depending on somebody with a ruler. When you look at the basic baseline characteristics, the standard of care looked just like the standard of care plus topical oxygen, and there really was no statistical differences between the two. We did get 54.5% of the patients were over the age of 65. And I want to thank the investigators. I mean, there's really a lot of hard work, particularly with this type of requirement. Now let's take a look at the results. Now, in clinical trials, the idea is to get a positive study on the intent to treat. What does that mean? That means that anybody that came in and was exposed to topical oxygen for any period of time would be included in the analysis. So the intent to treat includes patients that receive topical oxygen for only 2 or 3 weeks, and we're still included in the analysis. The per protocol analysis is when you treat the patients with, you only include the patients that get the full dose of oxygen. And for some, in my mind, per protocol seems to make more sense, but intent to treat sort of the gold standard in clinical trials. And you'll see here that we not only hit our endpoint of complete healing outcomes in the intent to treat group, but also in the per protocol group. And it was statistically significant. So we're really proud of this and proud of the investigators that made all of this happen. All right. When we take a look at the per protocol, those that actually got the doses of oxygen, we see you had 52% healed completely. Well, why wasn't it 90%? If you do a clinical trial and you get 90% healing, you did a lousy clinical trial. The reason is because that's just not reality. There's so many different variables that can go into it. It also probably means that you didn't do a very aggressive run-in period like we did, and we do in all of our diabetic trials now, where we eliminate those rapid healers. So 52% is actually really your goal in these clinical trials. If you look at the healing rates, much better for the NATROX group. And if you look at the how fast it's healing, the percent error reduction, much better for the NATROX group. You can conclude from this slide alone that topical oxygen is effective in the treatment of diabetic foot ulcers. And this truly is hard to heal diabetic foot ulcers. All right, percent error reduction. We mentioned this in the last slide, but I just wanted to show you the numbers so you think I know what I'm doing. But anyway, you can see that in the standard of care plus topical oxygen, you have a lot faster healing. If you look at the line here, it says mean standard of care 40 and standard of care plus topical oxygen 70. Huge. The wounds are just healing faster. Any advanced therapy that we test in clinical trials, you should see this. You should see this happen. They make the wounds heal faster, and that's a signal that this product really works. All right. So after the patients healed, we then follow them for a year afterwards, and I have to thank Dr. Omar Al-Jaladi, who was our fellow at the time, is now a surgical resident at the University of Toledo, because this trial finished in April of 2020. Which means that the long-term durability study had to be done during the pandemic. Nobody was coming into the clinic to have their wounds looked at. And Omar tracked all of these patients down. We had a lot of people taking pictures and FaceTime, and it just was a Herculean effort for Omar to get this done. What you see is what I expected. 78% of the patients who received topical oxygen remained healed at 1 year. 60% in the standard of care. Both are pretty good numbers, but why more topical oxygen patients? Because it's better healing. In the first slide, I demonstrated or showed that you have better collagen formation when you're in a high oxygen environment. It makes sense that these wounds have a more durable healing. This is from our meta-analysis led by Marissa Carter, which demonstrated that if you take all of the clinical trials that have been done recently on topical oxygen, that you get an overall very good grade for the use of topical oxygen. So this is a strong recommendation for the use of topical oxygen. In a retrospective study, Hannah Kaufman not only looked at diabetic foot ulcers, but actually the most common ulcer that she looks at is a venous leg ulcer, the VLU, and about half of her patients there. And she went back and looked at healing rates. Now, this was actually done before our clinical trial, but what we see is that you get excellent healing in both venous leg ulcers and, as we saw, diabetic ulcers. I concentrated on this one, really on the venous leg ulcers, because after we got these great diabetic foot ulcer results, I mean, they're really outstanding. We say, well, does it work on venous leg ulcers as well? We'll talk about that in a minute, and I'll tell you about some of the ongoing plans for further research. All right. So this is a study out of Karolinska in which they looked at the promotion of venous leg ulcer closure. Now, I have a number of patients in a case series, and Drs. Cole and Wahab will share more case studies with you, but that demonstrate that topical oxygen is also effective in closure in venous leg ulcers. And I think that makes sense, this promotion of epithelialization that oxygen provides. One of the really interesting things about this study, though, is look at the pain scores. pain before topical oxygen instituted and pain after. And one of the other things they studied in this study was the use of opioids. So opioid use also went down after the use of topical oxygen. I wish I had a great explanation for you. Maybe it's a change in the microbiome, but I don't know for sure. But clearly, this is something that they saw in the clinical trial. After we looked at this trial, we started using topical oxygen for patients who had venous leg ulcers and severe pain, and we observed a very similar phenomenon. I will tell you that we have now designed a clinical trial to look at venous leg ulcers that are painful and use topical oxygen, not only to look at complete closure and percent error reduction, as we did in the diabetic study, but also to investigate more carefully this pain reduction phenomenon. Could topical oxygen be indicated for pain? I think that's a possibility, and it's something we're looking at right now. There was in 2023, there was an international consensus document. A lot of you who are connected to me on LinkedIn, and please, if you want to connect with me on LinkedIn, please do so. We're asking for this document. So I just this week, we reposted this international consensus document. It's really well done. And that's not because I'm an author. It's really the folks at JWC do a great job at organizing these types of consensus documents. And it's something that you want to put on your shelf or put on as a PDF. I'm not going to go through the whole thing, the whole consensus. I just want to highlight a few of the consensus panel recommendations. Now, this consensus is not just a bunch of experts getting in a room and saying, hey, I think this is how we do it. I mean, I'm afraid that in wound care, that happens all too often. I've already shown you that there's a tremendous amount of evidence for topical oxygen therapy. So the panel has strived to make recommendations based on all of the evidence that we have and we're gathering. So just some basic recommendations. It should be considered for hard to heal wounds. And again, that comes straight from the clinical trial work. And I think an earlier consideration rather than later. And I've learned more about this number 5 here, because you take a patient as a non-healing venous leg ulcer and you've tried compression and other modalities, and they have a lot of pain. I think an earlier use of topical oxygen clearly is going to be beneficial in those patients. And again, we'll have more evidence for that coming up this year or early next. It's adjuvant use along standard of care should be considered, and the treatment of obviously the underlying problem is key. If you put topical oxygen on, don't compress the patient if it's a venous, or don't offload the patient if it's a diabetic, it's not going to work. And then I mentioned important management of pain so you can read all these. I'm not going to go through. Use all my time up to go through all of these aspects, but this is a great document, extremely well done. And like I said, if you go on LinkedIn, you can download it from my LinkedIn. So topical oxygen is now on a number of international guidelines. The American Diabetes Association back in last year, the International Working Group on the Diabetic Foot. I think it's also NIH in England, and you can just read through these guidelines, including the most recent Wound Healing Society guidelines in diabetic foot ulcers. So I think this is another strong recommendation. And all of these societies, like you look at ADA, for example, they look at the evidence and they grade the evidence much as we do for a meta-analysis. And they say, well, let's look at the preponderance of evidence here. And then you recommend it. So ADA, that's why ADA is given an A grade. And that's the highest level. Very strong evidence that supports the use of topical oxygen in the treatment of diabetic foot ulcers. All right. Well, this is me. This is my email. You're free to email me, connect with me on LinkedIn, and we can have a further discussion. And I'm going to turn it back over to Rich, and I can't wait to hear the other speakers.
Fantastic, Dr. Serena. Absolutely. It's so amazing that we now have this modality available, that clinicians have this modality. Most of the questions we're going to take are going to be in the Q&A. However, we have about 6 minutes or so before Dr. Cole's presentation. So you were great. I could have stayed on a lot more before you started. But what I'm going to do, we have about 103 in the room right now. I'm going to put up a poll question, and encourage everybody just to click on the screen. And you've heard a little bit about topical oxygen therapy. You're going to hear obviously a lot more as the event goes on. But if you wouldn't mind, just simply click yes or no. I said, would you consider adding topical oxygen therapy as an adjunct to your routine care? I think the portable, component of it all really speaks to the use by the patient, right? Like you said, everything is moving in home. And so that really adds to that. Let's see if we have any questions. Do we have any questions on that? Or Dr. Serena, you want to add anything?
No, I was going to say, one thing is I didn't mention it up until recently. I was the medical director for Mendota Health. I'm still a consultant. And that's the delivery of advanced wound care in the patient's home. And I think if you're looking to develop a device in the future, it better be something you can take into the patient's home. Because if you can't, if it's not simple, easy, and wearable, then I think you really have to reconsider whether that's going to be a viable device in the future.
Mm-hmm. There's always the question of insurance coverage. I mean, that's always a question. George Carduce asked that question. What about insurance coverage?
So right now, I may not be the best person. I'm a researcher, so I may not be the best person to talk about insurance coverage. I know that we're working on obtaining Medicare reimbursement, and I'm not exactly sure what the holdup there is. I would have hoped we'd had it by now, but I will tell you that in the future, we foresee that we'll have Medicare coverage. Some states have coverage on Medicaid, and I would suggest they talk to the folks at NATROX and they can give you all the details. I'm not an expert in coverage.
Exactly. Sonia asked, do you have any patients who get oxygen therapy from the beginning, not failed standard of care therapy? It would be nice, speed up healing without going through the obstacles, shorter time, lower cost.
Well, we're probably gonna have to wait for population management for that. When Medicare just gives you a bunch of money and says, "Hey, here's all your diabetics, take care of them." In that case, I think we'll use advanced therapies earlier than we do now. But remember that the national coverage determination, where you are, your local coverage determination, is going to require 4 weeks of standard of care. That's why the trial was designed with 4 weeks of standard of care, and during that 4 weeks, they couldn't heal by more than 40% or 20% in each 2 weeks period. And that's because that mirrored what Medicare requires for any advanced therapy, whether it's a camp or whether it is topical oxygen. So with the trial mirrors real life, and that's a requirement. So it's a great question, but if we're going to get paid, we're going to have to follow Medicare's guidelines. And his sister Mary Joseph used to say, "No money, no mission." So we're going to have to get paid.
True. How do you assess and determine the appropriate situations or wound types for prescribing topical oxygen therapy to your patients?
So diabetic foot ulcers make up the majority of the evidence for topical oxygen, and I think it plays a really an important role. It's a good adjuvant therapy. I'll tell you something else we're looking at right now, which is really interesting. Again, I'm going to jump a little bit outside of the medical literature, and if you think about antibiotics, you get a bolus of antibiotics, and then you might get orals, or you might get less antibiotics. And why wouldn't oxygen work in a similar fashion? Mm-hmm. So is there a role to do a bolus of hyperbaric and follow that with topical oxygen? I don't know the answer to that, but it's just an idea, something we're playing with now. We've got a number of patients that we're considering this type of therapy for. So that's something to look for in the future. I'm sure we're going to have publications out this year on looking at some kind of bolus, some kind of mix marriage between hyperbaric and topical. I think it just makes a lot of sense. The research hasn't stopped. We've continued both on venous leg ulcers, pain. We're looking at pressure ulcers. We're looking at these combination therapies. One of the real nice things about this particular device is that you can use it with a lot of different things.
Exactly.
So, and that's a huge advantage.
Absolutely. So Johnny and Scott, we got those questions on tap. We're going to get to those, but we're going to move on to Dr. Cole's session and keep this event on track. Thanks, Dr. Serena. I'll see you soon.
All right. Thank you.
Take care, my friend.
Bye-bye.
All right.